And thank you all for joining us today. As many of you are aware, because you're joining us, you know that Botox has really proven itself to be quite useful for treating many conditions and helping many patients. We understand that, and a lot of thought has gone into this LCD. There are several Medicare administrative contractors that put their thoughts together on this, but it is also a very large and comprehensive LCD. We knew as we took a step back from this that if we were going to make this hour useful for you, what we really wanted to do was focus on something very specific that is likely going to be a cause for almost immediate consternation, and that would be if you're a hospital outpatient department and you need to seek prior authorization for Botox. We know that it is likely you are going to be nervous first about the changes. So we want to go over those today and show you areas that are going to make your lives much easier. All right, so today, obviously, we want to learn about the significant changes to the LCD that could directly impact prior authorization requests for Botox services. If this doesn't necessarily affect you, I encourage you to stay on anyway, because I think all of this information can be useful for anyone who has Medicare beneficiaries for whom Botox is a useful modality. So today we're going to review the LCD changes specific to the prior authorization services. We're going to discuss the coverage criteria for prior authorization services, really get into the nitty-gritty, and we're going to review those documentation requirements. This was a most often pre-submitted questions, and thank you all. I want to make sure you all know, those of you who were generous and sent in some questions for us ahead of time, we got a tremendous number. These were so helpful in our construction of this session because we wanted it to be useful, and we wanted to hit those areas which we knew were going to be on your minds, and certainly documentation was a big one. So what has changed? Well, I've got a live link here for you for our new Botox injection LCD. It was released January 8th and it's effective February 22nd, which means this kind of our witching hour for getting our understanding of this really ramped up. There's some new guidance that affects this prior authorization of Botox services, and I also want to commend our prior authorization department within WPS. They really stepped up. Let me tell you, this is a hardworking group of colleagues and professionals who know and understand where your pain points are likely to be, and they wanted to make sure that we put this in front of you so you had a chance to see it, to understand it, to deepen your understanding of it, and to work with us in future so that our Medicare beneficiaries get what they need, and that you also get paid for the work that you're doing. So we're going to talk about coverage in general terms that applies to all or almost all of the LCD, and then we'll talk specifics. But I think it's always useful to take that sort of larger, higher level view and then dive down deep. So let's start at that higher level. So one of the things, of course, that is most important is that the type of Botox that you're using must be FDA approved for that particular diagnosis. And I'll say that again, that when you're looking at your particular modality, whatever you're using Botox for, be it migraines or other things, you want to make sure that you're using an FDA approved Botox type for that diagnosis. It is very important that you not give it more frequently than every 12 weeks, unless it's indicated under a specific diagnosis, and we'll talk about that. And then also, and I want to caution everyone about this, when you're using Botox for an approved diagnosis, if it's also being used concomitantly for a cosmetic purpose, it is not then deemed reasonable and necessary. So that is, use caution when your providers have that extra doses sitting there, what to do with those and how to document that, and we'll talk about that. Okay, so let's also talk about what you need to document ahead of considering someone for Botox. And we'll talk a little bit at the end about what happens when you've got a patient who's been on Botox for a long time, because I want to make sure you understand. We understand that's probably the majority of you. So it's really important for us to understand what conservative treatment, if it's appropriate, was done for this patient and why and what was the response. Was there an intolerance? What was that intolerance? What did it look like? What was that patient experience of it? Was it simply an inadequate response to those conservative therapies? Many of your patients, if they get to the point where they need Botox, they've been through a lot. Trying to capture that as much as you possibly can is really important. And we understand how challenging that can be when you may be the specialist or the subspecialist seeing that patient. For the most part, image guidance is not reasonable and necessary. And specifically, that modality is ultrasound for the most part. We're not talking about EMG, we're talking about image guidance specific to ultrasound. We also want to make sure that you know where to find the billing and coding document for botulinum toxin injections. And that link is also a live link included in your slide deck. We wanted to make sure all of this worked. We also want to make sure that you know where to find that. Remember that LCDs and billing and coding articles are companions. An LCD is specific to the policy. Billing and coding articles allow us to build out what it is that we're going to, what diagnoses, what types of botulinum we're going to use for diagnosis. It's a little more flexible and it gives us an opportunity to examine those things separately. It's a very important part of the LCD process. Okay, so let's dig in a little bit. Hopefully you all are starting to come up with questions and things. We very much want those. And we've devoted a little extra time today for this because we know how important it is. All right, so let's talk specific to the prior authorization process, again, for hospital outpatient departments of botulinum toxin. Okay, so this list of codes, these are the affected codes for the PA or prior auth process. And I'm going to leave this up for a second because I know a lot of you are superhuman and you actually know some of these codes better than you know the long descriptors. It always amazes me. I think it's incredible. But these are the ones that are going to be affected the most often. Okay. We're going to spend a little bit of time on documentation. I know as a physician myself, especially in the hospital world where I functioned, this was always the bane of my existence. It was also the way that I told my colleagues what was happening. It was the way that we are able to substantiate what it is the patients need and what it is ultimately we're billing for. All right, so we want to make sure first and foremost that the diagnosis for which we're using the botulinum toxin is approved per the article. This won't surprise you. If anything, it's been expanded since the last time. I don't think anyone is going to trip over themselves about what's on the article compared to what was on there before. But I will say that one of the things you can do to make your lives easier is to really think about those things that we would need to know in order to know that this person has progressed to the point where botulinum toxin and its injection is really the most appropriate treatment for that patient. And that includes not only did it work last time, but what was the inciting reason for the Botox in the first place? So for example, if it's migraines, we need a little bit of information about that patient's migraine history. We need a little bit of information about that patient's neurologic background, the things they've tried corticosteroid, etc. We'll go into the weeds on that a little bit more later, but I really want you to be thinking about what can you tell us about that patient that's going to make it easy for us to understand that that patient has arrived to the point where Botox injections make the most sense. You want to document very well the sites of those Botox injections, the planned sites of Botox injections, the previous sites of Botox injections, and what the patient has responded to. You want to be very, very good about documenting the units of Botox that you're going to administer and then the ones that you actually administered. And we know sometimes in clinical practice, those are different. All right, we also want to make sure that the type of Botox you are requesting matches on the prior authorization form the Botox type that you inject. And that is really important, and that's unfortunately sometimes a source of consternation on the part of our providers, but it doesn't need to be. What's planned is what's executed. That makes the most sense, and it has to match for us to move on to payment. And then we do expect these to be 12 weeks apart unless otherwise stated, and we'll talk a little bit about different scenarios where that might be true. All right, so the first condition we're going to talk about are blepharospasms, and I have a soft spot for this condition. We got a lot of feedback within our response to comments after we posted the draft of our original LCD for comment. And we had story after story of what a difference Botox makes for these patients suffering with this particular condition. As many of you know, it's involuntary, it's forceful eyelid blinking, squeezing. It's difficult for people to keep their eyes open, and it is functionally very impairing. People can't drive, they can't read, they can't cook. It is incredibly impactful on folks' quality of life. There are 2 approved Botox types, Botulinum Toxin A and Toxin A. And I knew I was going to mess that up as soon as I said it in front of everyone. But that's all right. You all know what I'm talking about because you do this all the time. We need proof of chronic blepharospasm, okay? So this is not a temporary condition. This is one that's gone on for some time. And I think it's fairly easy for those of you who treat these patients to document. We know that it's occurring at least 30 days. So it's gone on for at least a month prior to that initial Botox injection. The other thing that I want to make sure we talk about, because this may be different for some of you, is that we really require an objective clinical scale. We want to know the severity and the impact. Now, do we care which scale that you use? No. Is it okay if you don't have an initial objective clinical scale because you've been treating the patient for a long time? Yes. Is it important that we still expect a scale to be documented at the time of injection? We do now. We want to know that that patient continues to respond to treatment, and we appreciate that effort that you're putting in to making sure that those patients continue to maintain their appropriateness. That's not to say that they're not responding to treatment. We're not expecting these patients to go off treatment just to demonstrate how severe it is. Not at all. That would be cruel and unusual, and certainly not the type of care we want to deliver to our Medicare beneficiaries. But we do want some effort to be spent in getting that severity level tracked. All right, as we mentioned, 2 types of botulinum toxin are approved, also not only for initial, but this is subsequent injection. Yes, someone asked if they'll have access to these slides. Yes, you will. And in addition, we're recording this presentation, so if you miss anything, we'll be sure to send you the link within a couple weeks. So yes, we have an initial dose here, upper lid and lower lid, and yes, we do pay attention to the muscles that you're injecting, so make sure you document those well. We always like to make sure that there's informed clinical decision making. And of course, that goes beyond informed consent we assume that you're doing that, but we want to make sure those beneficiaries understand that what the other opportunities might be for treatment, what that looks like, what those discussions have been for potentially amplification of those doses. I mentioned the objective clinical scale, and then of course, being able to document persistent or reoccurring moderate to severe blepharospasms. And you do have those opportunities, sometimes inadvertently. Someone misses a dose, or perhaps they're on vacation, or perhaps you thought they could go an extra week or two. Document that and make sure that we see that as well. See, I know you all do this work. I know you do it very well. What I want to make sure we do is share with you those pieces of information that are going to help us loosen that lid of the jar and make sure that your claims get paid. You do hard work, you do good work, and we want to make sure that our beneficiaries are getting good care and your level of frustration is minimized. All right, so with blepharospasms, if the first injection lasted less than 8 weeks, what we want you to consider is increasing the dose up to 5 units total per site. And then at that point, we don't expect that. Oh, and sorry, I misspoke. And then if the treatment lasted 12 weeks or longer, we don't expect that there would be a need to increase the dose. Okay. Now, for those patients who are lucky enough not only to have blepharospasms, but also getting associated orofacial dystonia, or otherwise known as MIG or MEG syndrome, what's the initial injection? So Botulinum Toxin A is approved. There's not necessarily any dosing because of the differences in clinical presentation, but we do know that largely, in addition to blepharospasms, they have contractions of that jaw and that tongue. These are associated, and they tend to be chronic. Moderate to severe is the type that we would expect you to be treating with Botox, and we want that documented as much as possible with that objective clinical scale at baseline and after each injection. Again, we don't mind whatever scale you want to use as long as you're able to document it and have it be demonstrate changes over time. We also want those units to be injected, how many, and we want that to be documented on the prior authorization request form. Okay. Again, informed consent is very important. We also want to make sure for subsequent injections that you've got that chronic documented, that it's moderate to severe documented, and it's okay if it comes from previous documentation. We just want to make sure that it's there for us to see, that it's easy. We know you know why you're delivering Botox, but we need to know it, and then the best you can do is probably not only a progress note, but maybe even the initial consultation, which would have all that information, unless you have one of those clever EMRs that pulls it all in for you without having to do so much as Wink. All right, so obviously we want scales at baseline and after each injection. We want documentation of the spasms returning if they do, and what that intensity is before another injection is given. And this is important. If the injection wears off prior to that 8-week mark, an increased dose at the time of administration can be given. Okay. So we're going on to cervical dystonia. And the bad news about this is that we put these slides together before we discovered the good news, which is this is no longer part of the hospital outpatient department prior authorization process. Now, we made some nice slides. So I will certainly, we save them and we're keeping them in here, and you may have them, but we don't necessarily have to talk about this condition. And as you all know who treat it, it is greatly impacts the patient's quality of life, and these treatments do amazing things to help get folks their lives back. Okay. speaking of which, let's talk about migraines. I'm willing to bet that if we have over 200 plus people in the audience, that about 10% of you, or at least 20 of you, suffer from migraines. It is a very common condition. Many of us have friends, relatives, partners who suffer, and we all understand the absolutely debilitating condition this can be. We now know a lot about migraines. There was a time when we did not, but we're very keen on, we understand that these are very different from a simple headache. They're often associated with sensitivities to light, sound, or smell. They can cause nausea and vomiting. Worsening of that migraine with slight physical exertion, such as bending over, walking, going to the bathroom. If you've ever seen anybody walking with a migraine, you know what I'm talking about. We also know that for initial injections, patients really have to have tried a good number of things, and their migraines need to be of a certain severity. So we know that if we're going to use Botox, it's being used for migraine prophylaxis, that is to say, not after someone has a migraine, but to try to prevent them. And that's, if you talk with a migraine sufferer, they would like that too. We know that for some severely affected patients, they get greater than 15 days a month of headaches, and they have monthly migraine headache days greater than 8 days per month, and their migraine headaches typically last greater than 4 hours on the migraine days. We also know that these chronic headaches are present for at least 3 months, meaning that this is not a new migraine sufferer that would raise a lot of red flags and perhaps require a different workup. This is someone who's had these perhaps lifetime, perhaps since attaining puberty, et cetera, et cetera. We also, as far as documentation, would really like to see that there's a 2-month trial of inadequate response to at least one agent in any of the 2 classes noted, or someone has contraindications to the following medications. So some of these medications would be things like, for example, the antidepressant classes like amitriptyline, nortriptyline, duloxetine, beta blockers. We used to use these all the time, and actually they can be very effective. Metoprolol, propranolol, atenolol are some names. Calcium channel blockers, they can be also terribly effective, such as verapamil. Obviously, if you have somebody with low blood pressure already, see, there you go. There's a example of a contraindication to one of those medication classes. And then anti-epileptic drugs that we used to use, such as gabapentin, valproic acid, those sorts of medications, as we've discovered, can be useful for a wide number of conditions. Okay, so within that 2-month trial of an oral pharmacologic class for chronic prophylaxis at the target dose, or of the usual effective dose, or an intolerance of the 2 agents in each class, and if they're currently using a calcitonin gene-related peptide receptor antagonist. Those are the very new sexy medications that a lot of folks find to be life-changing for chronic prophylaxis. But let's say you have a patient who's on them, had a reduction in their overall number of migraine days, yay, but they still have a large number of beyond an acceptable number of severe migraine days per month, and or they're requiring additional therapy for prevention. That would be an excellent candidate for Botox and that receptor antagonist therapy together. We also want to see that these headaches are causing an objective, significant functional disability. This does not have to be, a novel. The person is missing work. They're unable to drive. They're unable to pick their child up from school. They're unable to enjoy the baseball game because of the bright light. People will tell you, they will divulge what it is that they can't do. Typically, people come in because of that functional disability. We want to see, of course, headaches are moderate to severe in intensity. Anyone with a typical migraine does not have a hard time selling that to their providers. And of course, and we've talked about this before, the serotype of the botulinum toxin that you choose is approved by the FDA for this use for chronic migraine prophylaxis. All right, so initial dosing. On botulinum toxin A, that's our typical, and the dose in the range between 155 and 195 units. And we have all of those muscles illustrated there for you because we expect somewhere between 5 units each site across the 7 head and neck muscles. We recognize, of course, that this is a unilateral view. Those muscles that we listed out here, they do in fact, they do matter, and I know you document those. Having the documentation for us as well is super helpful. All right. Continuing on with chronic migraines, and these get a little bit of airtime, right? Because this is a significant issue for a large number of patients. And as we've gotten more experience with botulinum toxin, we recognize how useful it can be for conditions like this. So what we like to see once someone starts botulinum toxin, that we've at least been able to have a greater than 50% reduction in migraine headache days per month. So less than half of the migraine headache days per month they were having prior to the Botox treatment. We'd like to see that their frequency of total episodes has gone down by greater than 50%, and that we have some sort of minimum important change and significant reduction of headache-related disability and objective improvement in functioning. I could get back to work. I only missed one baseball game last month. You all know what you're doing. Getting that social history, super helpful. All right. As you all know from treating patients who suffer with chronic headaches, biobehavioral therapy has been determined to be very appropriate and helpful for both prevention and acute headache treatment. So that could include cognitive behavioral therapy, biofeedback, relaxation, mindfulness, acceptance and commitment therapy. The gamut is wide-reaching, and there would be very little that we wouldn't note as being impactful here, as long as the patients tried it for a significant amount of time and concurrently with other agents. So we also want to see that if that patient has been on the calcitonin protein antagonist agent for prophylaxis, that they've had a further reduction in overall number of migraine days beyond that agent when you've paired the botulinum toxin treatment compared to what they were experiencing without it. And then also, and this goes without saying, that the serotype is approved by FDA for chronic prophylaxis. And I can see lots of questions coming in the chat. I'm very excited. This is great. As I've mentioned, you all are experts in administering these therapies, and we want to make sure that you are able to do this with a minimum amount of consternation and anxiety. So we've talked about this already. I won't belabor the point. I don't want to give you guys a headache, except to say at the end here, when you're increasing up to 195 units, we want you to do the follow the pain strategy. You all are very familiar with that. There's 39 potential sites, but more than 195 units will not be allowed. That is to say, for Medicare beneficiaries, claims beyond that amount will not be covered. Okay, so let's talk about hemifacial spasm and facial dystonia. You know, I really do appreciate the work that you all do, because when you think about these conditions, these are not these are not things people can forget about. These are things that affect everything. TV watching, their relationships, etc. So I'm just so pleased to be able to talk to a group of people who are obviously dedicated to making sure that these patients get their lives back. All right, so for this particular condition, the hemifacial spasm or facial dystonia, the initial injection, again, the approved Botox type is on a botulinum toxin A. It's accepted as first-line treatment for primary or secondary facial dystonia. There's an objective documentation of clinical features consistent with the diagnosis of primary or secondary hemifacial spasm. You all know how to do that well. And then what we want is an objective scale. Again, we don't care which one you use, just be consistent about it with that particular patient, be able to measure severity, complexity, and the psychosocial aspects of having this condition based on the scale. Okay, so again, when you're looking at this particular condition, the dose is typically 25 or 30 units and injected into the affected muscles, which are typically those listed. We want to make sure that the list of muscles documented on your prior auth form and within the documentation makes sense based upon the patient's condition and presenting symptoms. For subsequent injection, we want proof of that informed clinical decision making. So it's not just consent, but in addition, we want to make sure that patients understand what it can do, what it can't do, and what the alternatives might be. We want to have that reassessment of the degree of persistent moderate to severe hemifacial spasm. Again, this is not a quiet condition. This is not dependent on the patient taking measurements at home, such as their blood pressure or their blood glucose. This is something that they will be able to tell you fairly readily. Sometimes symptom diaries are helpful, especially when someone's had a condition for quite some time. So you might find that beneficial for this and other conditions. But the most important part is that it's persistent, moderate to severe. And then we also want to see that it's been 12 weeks since that previous injection when that patient comes in to get their subsequent injection. All right, so subsequent dosing guidelines, we get it. Not every patient's the same. And we also understand that in general, these treatments are not only effective, but generally very well tolerated. And patients are going to want to have as much symptom relief as possible. Our LCD is based on the evidence that's available to us to read as well, meaning that it is based on studies, not necessarily your clinical practice. So we understand that sometimes there's some chafing with that, and we get that. But since the 21st Century Cures Act became reality in 2016, we have to derive all of our recommendations from evidence and very high graded evidence. So again, we want to give you as much flexibility as we're able to, but it's all based on evidence-based guidelines and evidence that is available to us as well. All right, so we understand that occasionally patients don't always respond or that response wanes over time. So you have an additional 5 to 15 additional units after 1 year, which we understand may be required. Again, documentation is really important here. Okay. So I'm hoping we left a lot of time for questions because I saw some come in. We wanted to do that on purpose. What we tried to do today, hopefully somewhat successfully, was we wanted to learn together about the changes to the LCD that could impact that Botox prior authorization process, those requests. We reviewed the LCD changes specific to prior auth or PA requests. We discussed that coverage criteria for prior authorization services in some detail. Thank you for sticking with me. And then we also reviewed those documentation requirements, or tried to the detail that we hope is satisfactory. I think next we're going to go to some questions and answers. We have had a large number of pre-submitted questions that we want to tackle. I think that what I'd like to do is hit those high notes first, and then if we have any lingering questions, and I know we will, because I'm trusting this very sophisticated audience to back me up on this, we will dive into those. So one of the questions we got, which I thought was really important one to address, is how far back on the documentation do we need to send with our authorization request? Well, of course, I'm going to say it depends. It depends on what diagnosis the botulinum toxin will be administered for, but a general rule would be, you know, the most recent history and physical, or perhaps the initial consultation note, the last 2 injection procedure notes, and any additional documents that we might need to paint that picture about why that patient really needs botulinum toxin for that condition. So baseline scale, their response after the Botox was administered, paint that picture for us. That is really, really helpful. And I get that when you're the consultant, you don't always have all that background. You may not have how many months the patient was on verapamil for their migraines before it stopped working. We understand that. It's all right for you to send in documentation that came in with that patient. It would be great if it's all in one place, but we understand that sometimes real life doesn't work that way. Send in what you're able to. All right, are we able to appeal a decision for prior authorization? Well, this is a great question, because for prior authorization, you're allowed to resubmit as many times as required to get that prior authorization for your patient. So technically it's not an appeal because nothing's been denied. What we've simply told you is that there's not enough for us to affirm that prior authorization so you can go ahead with the treatment. All right, next question that we have is, do critical access or private practice providers need to submit a prior authorization request? No, this is only required for hospital outpatient departments. There hasn't been any changes to this requirement. If you weren't required to submit for a prior auth before, you won't be expected to do it with the new LCD. All right. And does a prior authorization need to be obtained for each injection? Excellent question. Yes, the authorization will need to be approved to use within the 120 days. Yeah, so the short answer for that is yes. And then, are there additional prior authorization CPT codes that need authorization at this time? And no, there are no changes to the codes. 64615 and 64612 with the applicable J codes are the current codes that need prior authorization. And those are for you, for those of you who speak code. And I'm always in absolute awe of those of you who do, because you're amazing. I'm learning. So I think those are all of our pre-submitted questions. I'm going to now ask Candy to go over any of the ones in the chat that they think might be especially helpful.
Hello, everybody. A lot of the questions overlap, so what I'm going to do is kind of group them together, if you will. There was a couple of them that came in regarding cervical dystonia. I know that we used to see some auths come in for cervical dystonia that was under either 64612 or 64615. The questions coming in is related to, is that even covered anymore? Absolutely, cervical dystonia is covered. It just does not fit under the description for 64612 or 64615. So I hope that clears that up. You can reference the article also, and it gives all of the diagnoses that are covered based on the CPT code that it is underneath. Another one that we have a couple of is for the providers that are on the call that are on exemption right now. You will remain on exemption until this exemption period is over. So continue as you have. You do not have to submit for prior auth when you are on exemption, but just know that when you get to the end of your exemption period, you will be subject to these guidelines for anything that was given after the February 22nd date when we do the 10 claim exemption process. Let's see, I am looking through these. If there's other questions, you can put them in the chat and I will answer them for everybody. This is a really good one from Tracy. For Bleph, the LCD allows a dose up to 10 units on an individual basis. What documentation and criteria would be acceptable for use at that dose? The guideline pretty much states give a rationale, a clear rationale in your documentation as to why that beneficiary essentially needs those 10 units each site. And it's pretty vague. So as long as the rationale is there, it would be acceptable documentation for that. Let's see. The scales, I don't know if there's still questions on that. Dr. Velakis did go over that a little bit. Migraines don't require the specific scale. So, but Blepharospasms, Miege syndrome, and Hemifacial spasms do. They will be grandfathered in of sorts. It's the kind of the word that I can use for that. We can see we have thousands of these that come in of people that have been getting Botox for a very, very long time. We wouldn't expect that you try to figure out what the baseline was 5-10 years ago. But when you do submit, you would have a baseline before you give those injections again. It may not show at a moderate or severe level at this time, but it'll kind of prove that effectiveness is still continuing. That, Dr. Velakis, do you have anything else you want to add to that part for that scale?
No,
I
I think that's perfect.
Contention.
You know, understand, the burden of getting a scale every time, but it is one way that we can make sure our beneficiaries are getting effectively dosed. And as I alluded to in our talk earlier, a lot of how the LCD is written is based upon research, and that research for effectiveness with these therapies has scales attached. And so what we're trying to mimic is that excellent care that adheres to detail and adheres to the patient's response to treatment. But please don't get so hung up on this that the patient doesn't get what they need. Send in what you have, create a scale that works for your office. There are scales out there that are used. Again, don't get so hung up on this that the patients miss out on their therapies. Make sure that you're using something and you're using it consistently.
Perfect. Amber had sent in a question. It says for blepharospasms, it appears you mentioned 1.25 to 2.5 units into 3 sites each per eye, but then it appears there's a limitation of no more than 5 units per eye. What do you mean by sites versus total per eye? I think the 5 units is more, how is that worded in there? I'm going to pull that up, Dr. Velakis, if you
Yeah, I know
anything
it's
on
a shock
that.
that we haven't memorized this thing by now, but yeah, every time I read it, I appreciate something different and more about it. And I think your question is a good one. Sometimes the math is, but if
Right.
if you're measuring the patient's response and you have a rationale for what it is that the patient needs, again, we're basing this on evidence-based guidelines. We also understand that this is generally safe and effective, and patients do have demands. And know that, your Physicians, they have their own clinical judgment. We understand all of that. But this is what Medicare is able to cover and pay for based upon the evidence. It does not necessarily means that this is the end all be all and we figured everything out. In fact, let's pause for a second and talk about the LCDs as dynamic documents. Even this back and forth that we're having, really important for us to continue to keep our LCDs in step with modern clinical practice. The questions that you send us, the concerns that you have, they are read, each and every one. We got an extraordinary number of comments about this LCD, and we really did give a lot of thought to incorporating it. Is it a perfect document? No, it's written by humans and we are fallible, but we certainly did everything that we could with what we knew at the time. Believe it or not, things continue to change, I know, in modern medicine, and we do try to keep up. We also try to build our LCDs so they're somewhat flexible. Again, it's not a perfect system. It's dynamic, and we do expect that back and forth. Did you find what you were looking for, Candy?
Yes, she has it exactly correct as you mentioned it. So I guess the conflict comes in because of the math portion of it, where you have the 5 units per eye, but you can have 1.25 to 2.5 in each of 3 sites. So it's almost like you could go up a little bit in one of the sites is kind of what it
That's
comes
the way
down
I
to.
would
It's
interpret
written.
that as well. And you don't always
Yes.
need, right? Everyone, understands that there's often recruitment, and sometimes there's one inciting muscle that's the one that needs to get the additional coverage.
All right, I am going to go on to the next question. This is something actually that comes up currently to this day. This is from Gail. It says, can we treat the masseters with migraines? The way this is written right now, no, we cannot. Um, so they pretty much go by where they get this information of the sites is from the label and the FDA approvals for these. It's listed on their websites with the sites. The exact sites are actually listed also in the initial and subsequent dosing guidelines in the LCD that could be referenced. Anything you want for that, Dr. Velakis, we get a lot of the masseters still that it seems to be a popular site to treat.
Yeah, and I think one of the things that was a concern, one is that the evidence that we use to develop the LCD is where we got those muscles, but the other is that temporal mandibular joint dysfunction is not a part and parcel of a covered diagnosis for this. So I think that's part of the separation as well. That doesn't necessarily mean that your physicians are, prevented from doing the masseter. It just means that because of our coverage determination, it's not a covered area. It's not something we can prior off.
Here's a really good question. I guess I never thought about this one. Dr. Velakis said an ultrasound isn't medically necessary, but the code CPT code 76942 is in the coding article, and ultrasound is mentioned as payable in the LCD. Could you please clarify?
That one I'd probably have to table, and we'll put that in one of the questions that we will tackle later. And by the way, we do that. So seriously, if we don't know the answer right away, or if we don't get to your question, keep them coming because we will get to them.
Yes, and that's exactly why I wanted to bring it up because it is something we can follow up with for sure and get an answer because it's very interesting. And I will also dig into that one and get answers out to people.
I know I'm learning
We
more
have a
all the
lot of
time.
them about, we are. There are a lot of questions, and Mary Sue is helping answer questions about what facilities need these and who has to follow these guidelines. So, any Medicare patient that you serve with these injections, they need to follow this guideline. That doesn't mean that all of you have to submit for a prior auth. Okay. So the only places, if you will, that need a prior auth is the hospital outpatient departments. Okay. So private clinics, private practices, any of those, you do not need a prior auth at this time. Never know if it'll be expanded by CMS at some time. We never know, but for now, it is only hospital outpatient departments. Okay. There was a lot of questions for those. Here is one. Does it matter if the information needed is documented in the office visit note versus the last procedure note? By the office visit note, I'm assuming where when somebody comes in, they do vitals, you might have a past H&P, stuff like that. That is always great to send along because we generally get a lot of information from that. And with most of these, when you do the injections, they'll be on the actual procedure note, if you will. That is where we usually see the sites of injections, the dose of injections, and what type of Botox you used for those injections. That is usually the information we get off the procedure report. So if those things are covered and the documentation you need that's referenced in the LCD or article, you should be covered. I am looking to see if there are more that may be kind of, here is a really good one. Lisa sent this in. This is a question I asked exactly when I was setting some of this up. Dr. Velakis would be very helpful in explaining this. She explained it to me. Is there a list of approved biobehavioral therapies? And what would a biobehavioral therapy, I kind of put a couple together, entail?
Yeah, so Candy and I had a really good, it was more philosophic conversation, I think, than clinical about this. There is a very wide range of accepted behavioral therapies, and most of your patients who suffer to the point where they are considering botulinum toxin injections have used them. You just have to suss it out. So was it an antidepressant that could count? Is it cognitive behavioral therapy, biofeedback? Did they try and not like it? There are so many different modalities. There's a lot of apps that they might use. Document whatever it is that they tried, and it's very likely something that we can accept for prior authorization. What do you think, Candy? We talked about this for some time. Did I spin that the way we think?
Absolutely. Absolutely. I think as long as we see if you have a beneficiary that has some psychiatric diagnoses, if you will, and it'll be more important for your brand new patients too, that it just shows you're evaluating them correctly and the psychiatric portion of it isn't contributing to like blepharospasms or any of those other indications, migraines, stuff like that. It does not list out specific therapies that you have to use.
Candy and Dr. Bahakas, I'm going to jump in for a little bit and switch gears just a little bit, if that's okay with you.
Absolutely.
Sure.
All right. Well, perfect. I see. I'm just watching the chat and trying to help get everything organized behind the scene. I see there's a lot of questions that are still coming in regarding place of service. And I just want to go back and re-emphasize the fact that the prior authorization process itself is specific for the hospital outpatient departments that bill on a type of bill 13X. So not critical access 85X, not office visits, etc. As Candy said before, and it came through the chat and I answered this kind of generally to everyone, a physician's office can obtain a prior authorization on behalf of a hospital. However, what we are doing when we prior auth these services is we are authorizing the hospital to perform and bill the service. It's not the unique tracking number, the information that comes back, the approval is not specific to the physician's billing. However, it can later affect the physician's billing because if the hospital doesn't get the approval and we don't say it's okay to perform and bill it, then in essence, we should not be paying the physician either. So it could be that we recoup money on the back end from the physician as well. So it really is of utmost importance that as a provider and as a facility, you are working together. It's got to be a team effort. When you are going to provide, or your physician is going to provide these services in a hospital outpatient department, you really have to make sure you are providing that hospital with all the correct documentation that they're going to need to support that as reasonable and necessary. If you're going to submit on their behalf, you have to make sure you have all of the hospital's documentation to submit everything, and that when the affirmation is done, it gets shared with the hospital so they can put that unique tracking number on their bill. Otherwise, in the end, you know, it's going to affect everyone. Now, we've talked a lot today about the specific LCD changes and the LCD changes that affect this prior authorization process, because those are our first forward-facing providers whose stuff was coming in when these changes were made. This doesn't mean that if you're not one of those hospital outpatient departments that the LCD doesn't affect you. It very much affects anyone that performs blepharoplasty, botulinum toxin services. Getting a little tongue-tied there. So we really do encourage you to go out, read that LCD, read all of those sections specifically for the type of injections that you are providing, and make sure that it's covered, that you're following what you need to follow, even if the prior authorization doesn't apply to you. Now, in keeping the gear switch just a little bit, I want to pull Candy back in and ask, because there's been some questions that have come in about the exemption process. And when a facility's on an exemption, and I did put a link in the chat to our information on the exemption process. But Candy, do you feel comfortable talking just a little bit about providers when they are on an exemption and what they can expect for all their physicians that bill the Botox services if they're listed on exemption?
Absolutely. I mentioned a bit about it before, but maybe I'll go a little deeper. Exemption, if you are currently on exemption, you will stay on exemption. Providers that are on exemption, each year, what happens is 10 random samples, and it could be Botox, it could be SCS, it could be any of the prior auth topics. We don't know which ones we will get. So you stay on exemption. You still don't have to submit until your exemption process, if it would get terminated, you'd have to start submitting for every topic, not just Botox, but you would know that way ahead of time. But what you're facing is when those 10 random samples are pulled, if the date of service is after February 22nd, which is when this goes live, the documentation for those would have to be up to this LCD. If something would get pulled that was before February 22nd, we will review to the previous LCD. We wouldn't expect anybody to go back. All right. So you still do not have to submit, but it would be best to get all the providers in compliance with this LCD starting February 22nd, because it could be pulled for that end of year exemption audit of the 10 claims. All right.
Perfect.
Mary Sue,
And
did you
as
have
you're
more that
gathering,
you wanted to go over?
well, yeah, as you're gathering some of those other questions to go over, I'm just going to hit some of the, last ones that have come in regarding when I was speaking. And someone asked, can you tell us why you're coming down on hospital or outpatient departments? We're really not coming down on hospital outpatient departments. CMS put in place some prior authorization programs, which if you've been with Medicare long enough, you'll know that prior auth wasn't a thing in the past for Medicare. Like other private insurance companies, et cetera, had some prior authorization programs, but Medicare never did. So back years ago, CMS decided to pilot some prior authorization programs. They've done one in ambulance services for ResNat, repetitive scheduled non-emergent ambulance. They started this HOPD one. There's some other ones that are going on right now. But hospital outpatient department was the first place that it was trialed. So this is really one of the first prior authorization processes that have been put in place. So that's why it may seem like we're coming down on you guys, but we're really not. It's just where it started. Now, does that mean someday it's not going to be administered to all other types of service? Absolutely not. CMS can change their mind at any time, and they can put that, put prior authorization processes into place. And then there was another question about submitting just the 64612 and 64615, those codes, and not getting prior authorizations on other codes. Right now, those are the only codes required. So when those, along with those J codes, are submitted, those are the only ones that require prior authorization. Otherwise, you don't need to waste your time submitting a prior authorization request. It's not required. It's not needed by us. It's just a waste of your time, and it's a waste of one of our reviewers' times as well, because they have to shuffle through it only to determine that it's not necessary and to dismiss it. So at this time, I'm going to turn things back over to Candy so she can go through a few more of the questions that have come in. So Candy?
Mary Sue, I actually have one for you. It is about when will the on-demand, the recording be available? Because some people actually had to join us late. So we're happy you made it, but we do have this recorded, and Mary Sue can help you with that question.
Absolutely. Thanks, Candy. Yeah, you know what? I anticipate being able to have this on our YouTube channel by tomorrow. It takes me a little bit to, get it downloaded and re-uploaded and all the requirements, but it should be on our YouTube channel by tomorrow and for sure by Monday. Now it will be available on our website through the Encore link in about 2 weeks. And that's just because of the posting process and kind of the back and stuff. But again, available on our YouTube page, which you can link to right from the training center on our website, and it should be there tomorrow and at the latest on Monday.
Perfect. Thanks, you. Thanks, Mary Sue. We are getting a lot of questions about, because of all this units talk that we've been talking about, people are asking, well, now if I give 155 units for migraines, now I have to request 155, or for Bleph, if we only put in 50 units, I only get paid for 50. No, all the same rules that you followed before is the same thing now, because Medicare does pay for waste. So the same thing will go. If you're giving 155 units, you are allowed to ask for 200, just as you did before, because they pay the 45 units of waste. That's the most common that we see, or we will see 50 for blepharospasms that you're going to inject, but there'll be 50 of waste. So they'll go up to that 100 unit vial. So you would be requesting the same amount. You would still request 100 units for Bleph if you're injecting 50. So I hope that clears up kind of the unit stuff. That remains the same. So if you were submitting before, keep doing what you were doing before. Perfect. We don't have a lot of them that don't go to, the vial up to finish that vial. Another question, there's some about sites. I'm kind of clumping these together, if you will. There's some about sites. Now, unless the specific sites are noted in the LCD, let's use orofacial dystonia. The sites aren't listed where you are expected to put those. So we can't tell you exactly where they have to go, and that would have to be an MD decision. Dr. Velakis, do you want to add to that at all about the sites if it's not listed?
No, I think if it's not listed, you document as accurately as possible, and submit if it's a prior auth. If that's not part of the prior auth program, then you do your best work as you would normally. Yeah, I think it's okay. We always get into trouble in medicine when we try to constrict, prescribe exactly how people are need to practice. And there's that beautiful tension that can happen when you're trying to practice evidence-based medicine, but you're also very much dependent upon that excellent clinical judgment. So nothing that we have in this LCD should preclude excellent clinical judgment and excellent documentation.
Absolutely. We have several about TMJ. Oh, TMJ. We do see it quite often. One question kind of reflects if somebody comes into the office and you can see they might have TMJ going on, but your main focus is migraines. People wondering why they get denied. Because TMJ is not a covered indication for Botox at this time. And TMJ, it would obviously be head, face, or neck, which is what 64612 or 64615, the areas that it covers with those CPT codes. But the reason why sometimes these people with TMJ and migraines, and you're like, but I'm the doctor and I'm submitting for migraines, and they keep denying because I wrote TMJ in my documentation. It is only because on the actual procedure note, many times what the reviewers will look for is they want to know what diagnosis are you doing this procedure for? And sometimes there'll be 5 diagnoses listed on there. So unless they are specifically in the migraine sites, we have no idea if you're just giving them for all those other diagnoses, if you will. So on a procedure note, only the diagnoses that you're giving the injections for, and that then it doesn't matter as much the other diagnoses they have, if that makes sense. You're not giving it for those diagnoses, you're giving it for migraines. And that would definitely help in the review and determination process for everybody, us, the providers, everybody above. So I hope that really helps with that part. But TMJ, it is not covered at all in the Botox article at this time. All right. Even if it's not something for prior auth, it's just not a covered indication. I am looking for another question. I think there's some in here for urology surgeries, because urology, it's not head, face, or neck, and that's kind of our focus under the 64615 or 64612. You would not need a prior auth for those. As I mentioned with some of these other questions, though, if you would look at the parts of the LCD and article that affect urology, you would still have to follow these regulations for your documentation. It's just that you would not need a prior auth right now. All right. Mary Sue, are there any more that you have to address? I think we have a Parkinson's one here for neurology. We wouldn't worry about that. It wouldn't fit under the codes that we need prior auth for, but you would still follow the LCD. Let's see. I'm just scanning to see if we answered everything. Synkinesis. We were. Well. Are you? Yeah, synkinesis. We do see some of those come in. Those guidelines actually got a little easier for you, I'm happy to report. It used to be Botox was not the first line treatment for synkinesis, and you were supposed to go to a therapy prior to this. That is no longer the case. You no longer need to be going to facial retraining therapies, any of those types of things, speech therapy. So Botox will be considered the first line treatment for synkinesis. If there isn't a specific how the LCD is laid out, the big ones, let's say the big diagnoses, those are laid out with specifics, okay? Anything that does not have specifics, like we have Bleph has specifics, migraines, stuff like that. If it does not have a specific, please look at the top of the LCD and see the indications. So synkinesis, not a great big one, right? So you would still have to, you'd have to follow like the 12-week rule. There's no sites that isn't laid out for you. So you would just follow the basic indications up above in the LCD. It's very long. Much of it, though, if you look at it, I was a bit intimidated as well. Much of it is all of the attached research where all of the CMDs that got together got all the data to create this. So not a lot of it has to do with what's all expected in documentation or for these patients. So it is much of the research. So it looks like I've covered most of the questions, even though I kind of put them together between me or Mary Sue, we did cover them. A lot of sites ones with the sites, if it is not listed with specific sites, like migraines is a good example. We can't check sites, right? That would be up to the MD that is treating the beneficiary. I think that we're through them unless Mary Sue found some. They were coming in pretty quick.
There's one, yeah, and I'm just kind of on the bottom of the list scrolling up, and there's one that came in from Sonia that was asking about submitting a prior authorization for the 64615 for the provider and the J0585 for the outpatient hospital that supplies the Botox. So if the service, Sonia, is being performed in the outpatient part of the hospital, if it's a 13X type of bill, so a IPPS hospital outpatient service, the 64615 and the J0585 would need to be part of the request for the hospital prior authorization request. So there is no prior authorization request for the physician themselves. The prior authorization request only applies to the hospital performing the service. And then I'll turn it back over to Candy. There's some questions about the assessments. I don't know if you want to hit that as well.
Yeah, I was just looking at those. An objective assessment must be performed and documented at baseline, after each diagnostic procedure, and at each follow-up assessment using the same scale during each assessment. Most of these patients are only seen at an injection appointments, such as every 12 weeks. Are providers expected to bring patients back for a follow-up visit in between injections? No, absolutely not. So, I'm sure you're somebody, Tony, that is used to how we do migraines, and we do not want to cost Medicare more money and have you bring them in. It's just that when they come in for the next appointment, you would fill out that scale, okay? We don't expect you to bring them in between at all. So
Great question,
migraines, what we do right now.
So glad Tony asked it. That's a great question.
Yes, and we struggled with this when we started prior auth for Botox 5+ years ago, right? So the only way to make this where it's not more burden for providers or costing more money, making somebody come back in, is we look at the last two. So we actually kind of go backwards, so you don't have to do the follow-up, or we had nurses that were having to call and fill out the forms and stuff like that. So that will remain the same. You will not, that will not change at all. Okay. Dr. Verakis, I have one that is kind of, might be able to help with this a little bit. We have patients that the masseters are involved as part of the migraine path. Could injecting the masseters with the other 40 units, would that be covered under the follow the pain new criteria? That is a good question.
That is an excellent question. Wow.
It is. It is.
That is really good, and I'm gonna have to think about that one, because certainly I get that. You know, my initial response is no, except that's an excellent way to use what you would normally waste, and it's not cosmetic, so that's wouldn't necessarily be. I think it might fall under the reasonable and necessary criteria, but I'm gonna, if it's all right with that viewer, I'm gonna chew on that one a little bit, because it's so good. And I might even bring it to our Botox work group. To talk about it, because I think that's one that needs to get kicked around a little bit, because it's a really thoughtful question.
There's one for you guys that I've seen kind of
with.
I'm so sorry, Candy. There's a question
Go ahead, Mary Sue.
also that I've seen kind of kicked around between, you know, at various places, but can you talk about what those scales actually are that you guys are referring to?
Well, the short answer to that is no, because you can use the ones that you you find useful. I can, you know, what we could do actually is I know I can get some, grab some, and then we can share those with our attendees. I didn't think to do that ahead of time because I didn't know everyone would be so interested. I think it's great. But yeah, there's some that are available. Many, you guys will look and see that we have about 330 articles and resources that we use to construct our LCD within our bibliography. And I know that several of those articles have specific scales that they used as part of their patient response determination. So we can take a look at those and distribute if you like, if you're in sore need of an extra scale or two.
Definitely, I can include that when you guys get follow-up questions together. That's a great point. We can send that out. And the one thing I just want to also add to that is whatever scale you do choose to use, make it consistent. So every time that your patient is coming back and you're reevaluating, make sure you're using the same scale. Or if you guys have started to use a different scale, a different type of measurement, like just, you need to make note and document the fact that it's changed within your facility and how things are still similar or not similar from, you know, their previous assessment. Because we're looking for that consistency upon review. I do see there's a question that I'm going to answer before I let Candy jump back in. And someone had asked about an E&M for the assessment or if it was included in the procedure. And I can't say yes or no, just right off the bat, because the E&M and the procedure would need to be separate and distinct from each other. So if the E&M services, the part for the assessment, is actually included in the description of the procedure, then no, you can't bill an E&M separate from the procedure. But if the services are separate and distinct, perhaps you can. Now, the thing I encourage you to do with that, and this applies to anything and not just Botox, but anytime you are perhaps doing a procedure with an E&M at the same time or considering that, take all the information regarding that procedure out of your documentation. Just eliminate all of it and look to see, is there enough information left that I could support the need for a separate E&M service? If the answer to that is yes, then perhaps you can build those together. So I'll give it back to Candy. We could probably do one more question before we have to go to closing remarks. So Candy?
Okay, I am getting back to you. I had a good one and I kept going and now I lost it. Let's see, I see your E&M one.
And then I see there was kind of a follow-up to the E&M, so patients cannot have a follow-up appointment to discuss their progress from Botox migraine management on the same day that they have a Botox appointment. If it was, again, separate and distinct, and we need to see that the documentation, you know, is separate. And, you know, that the procedure is the procedure and that the E&M is the E&M. And if all the information that's gathered during the E&M visit is really supposed to be part of the procedure, then no, you can't bill them both at the same time. All right. And with that, we are right at about call-in time, and I want to be respectful of everyone's time. And I have made note of all the incoming questions so we can make sure if they were not answered during this event that, you know, we are providing answers for those. So in the interest of time, I am going to proceed because we've really slowed down in questions anyway. So I am going to proceed to some closing remarks. But be assured, we will get to your questions. And some of them are similar, so we'll group them together, we'll formulate those answers, and we'll send them out. So I'm going to have Candy, make sure you are on mute. Dr. Valhakis, same. Make sure you're on mute, and I'm going to finish with some closing remarks. So on your screen right now is some information about our survey. We want to know what you guys think. We want to know if this worked for you, if you liked this event. But mostly, we want to know what else we can do for you. So we do encourage you to take our survey. We know people get survey fatigue, but it's important that we know that we're satisfying your needs and bringing you information that's valuable to you. So I've put the feedback link into the chat, but the nice part about our survey is it gives you the opportunity as a provider to tell us what else you need. We take all of those questions very seriously and take them into consideration for upcoming education. So please, if you could take some time right now while we're still in session, go ahead and take that. It only takes you a few minutes, and we really appreciate any feedback that you can give. So with that being said, we can move on to the final slide. And if you think of any questions regarding this event, I want you to email those questions to us. So in the chat, I'm going to put the email address, and you can email those to us within the next 7 days, so in the next week. After that, the questions really need to go to customer service. Now, if your question comes in later than that, are we going to kick it away? No, probably not. Don't send us any PHI or PII. None of the three of us have access to the claims processing system, so we can't see that information anyways. We can't get into it, and we really don't want you sending any kind of PHI or PII through an email. That would get you in trouble. That would get us in trouble. So if you have something that's claim specific that you need to get looked up, go ahead and take those to customer survey or customer service. And then Dr. Valhakis, if you can advance the slide. All right, perfect. Just so you know, pay attention to the notes section of the slide. There's additional information in there about how to get a hold of us if you need to. You're going to get an email in your email box in a little bit here, thanking you for attending this event as well. And that email does contain some contact hours if you need those for continuing education. So on behalf of Dr. Valhakis, Candy, and myself, as well as all of medical review and policy, we want to thank you for your participation in today's event. So this concludes our webinar, and you can now disconnect.